So good afternoon. I would like to thank the organizer for having me here. We'll move focus a little bit to look at the different types of optic disc, especially the pale disc and a swollen disc, and what would you do next if you see any of these scenarios. So let me show you this patient, a 34-year-old male who has come to you for a routine ophthalmic examination. The Snellen's visual acuity is 6.6 and 6 in both the eyes. And this is how his optic nerves look like. You can keep the lights on. Yeah, so what do you see? You can keep the room lights on. So what do you think? A young male coming to you for a routine examination with a normal Snellen's acuity. A lot of people answered Dr. Sihota's questions from that side. So here, any of these optic nerves appear abnormal? If so, which one? Since this is a class on pale or a swollen disc, I can tell you that none of the discs are swollen. So what do you think? Yeah, so Dr. Sood says that he's not very happy with the right optic nerve. And it does appear that right optic nerve appears little paler than the left nerve. So the question is, what do you do now? Patient has come for a routine ophthalmic examination and there are no ophthalmic symptoms, the vision is fine. What is the next step? So as Dr. Sood has been telling you for his talk, that you will do visual fields. But before that, if you are in your exam or if you are seeing the patient in your OPD, what are the tests that you will perform in your OPD? Yes, somebody there said that pupillary reaction or RAPD. Remember, when you are talking about a pale disc or a swollen disc, RAPD is one of the most important and an objective test of the optic nerve. In other words, when you are fraught with this kind of scenario where you are not very sure whether this optic nerve is normal or abnormal, you would perform the optic nerve function test in your OPD and then move on to do visual fields and other imaging tests, whatever may be appropriate. So the first optic nerve function test would be pupillary reaction or RAPD. RAPD is the most important objective test of optic nerve function. What are the situations where you will not find RAPD? Very nice. Remember, it is a relative test of optic nerve. So if both optic nerves have a similar damage, symmetrical damage, then you may not find RAPD, though patient might be having optic nerve dysfunction. Very nice. So relative efferent pupillary defect. What else would you do? Somebody said color vision. What is the importance of doing color vision in optic nerve dysfunction? We are talking about neurological dysfunction. Yes, red desaturation is what you're trying to say. Before that, how do you perform color vision test? What would you use? What method would you prefer? For a screening, Sciarra's pseudo-isochromatic plates would be good enough. Yes, but for a screening, even the pseudo-isochromatic plates are good enough. The two important things, if patient is in a presbyopic age group, then he must be wearing his full refractive correction. There should be enough illumination on the plates. Now, what if patient says that he is not able to read the first plate? You see in a Sciarra chart, first plate is 12. Patient says, oh, I cannot see even this. His vision is 624 and 12, whatever, where he's able to see a color vision. What is your interpretation? Yeah, the first plate is also called a test plate. Everybody should be able to read a test plate, provided patient has a good near vision. So if in the presence of good near vision, patient says, I cannot see 12, in all probability you are dealing with a non-organic or a functional visual loss, right? So you'll do RAPD or a pupillary evaluation. You are talking about color vision. Color vision is an important tool to detect optic nerve dysfunction. Not only that it detects dysfunction, in a scenario, you might be able to even differentiate between etiologies just by doing color vision. Does anybody know as to how would you use color vision to differentiate between different types of optic neuropathies? Remember, if a patient has inflammatory optic neuropathy, optic neuritis, two of the commonest optic neuropathies are inflammatory optic neuropathy, optic neuritis, or ischemic optic neuropathy. So in inflammatory optic neuropathy, dyschromatopsia or color vision loss would be much more than the Snellen's visual acuity. While in ischemic optic neuropathy, these two would go parallel. So if the vision is 618, and if it's an ischemic optic neuropathy, you will have a patient who will have about half of the color plates he will not be able to read. Versus in optic neuritis, the Snellen's visual acuity might be 6.9, but generally speaking, the dyschromatopsia would be much more severe than the Snellen's visual acuity, right? So pupillary reaction, color vision, important screening tool. Make sure that patient is wearing near vision glasses. That's very important. And in scenarios, I mean, you can't just go only by color vision, but if everything fits, then color vision might be a good indicator even towards etiology of optic nerve dysfunction. What else you can do in your OPD? Any other tests that you can perform? Optic nerve function test. So Dr. Sood mentions about fields. So before you go to a formal field, for your exam especially, you would like to perform visual fields in your OPD room, in your exam. So in the clinical setting, in the OPD, you can perform visual fields by 3 methods. One is confrontation, using your fingers and showing the fingers in different quadrants. And I would request you to read up the confrontation techniques, especially people who are writing the UK exams. You should be knowing how to perform the confrontation test, because you will be expected to perform it in the exam. So confrontation test, Emsler chart. Emsler chart is a good way to chart a central visual field. And as somebody was mentioning, red desaturation. Remember, desaturation of red color is one of the earliest signs of optic nerve dysfunction. So you give patient a red target and ask him to see if the red color appears the same between 2 eyes or between 2 quadrants. So desaturation of red color is one of the earliest signs of optic nerve dysfunction. Remember that. So you'll do pupillary reaction, you'll look for color vision, you'll do visual fields. The 2 more tests that you can perform are brightness sensitivity test. Brightness sensitivity test is like an alternate cover test. It is performed in a dark room. Patient looks at a bright source of light, and you perform alternate cover test. You ask the patient to verify, is there a difference in brightness between 2 eyes. It is sometimes also called a subjective RAPD test, so meaning thereby that it is also a sensitive test of optic nerve dysfunction. Patient having optic nerve dysfunction, patient would be able to appreciate a reduction of brightness on the side where he is having optic nerve dysfunction. So RAPD, color vision, confrontation visual fields, brightness sensitivity test, and contrast sensitivity test. These are the tests that you will perform if you encounter a person like this, where you're not very sure whether a particular optic nerve is abnormal or not. If all the optic nerve functions are normal, what would you do? Patient has come to you for a routine checkup. You find that maybe right optic nerve is pale, and your optic nerve function tests are normal. What else can you do? What is the next step? We are talking about an approach. So step number 1, step number 2, what is the third step? As Dr. Sood has been mentioning, now you perform formal fields and see if you are able to see any visual field defect and an OCT. Sometimes OCT might give you a significant loss of nerve fiber layer, even in the absence of any major impact on the visual acuity. So anybody knows what are the other uses of OCT in neuro-ophthalmology? Where else would you use OCT in your neuro-ophthalmic assessment of a patient? Any ideas? OCT has also been used. Suppose patient has pituitary adenoma. What kind of visual field defect he'll have? Pituitary adenoma, chiasmal compression, bitemporal hemianopia. Right? So if the patient comes to you with bitemporal hemianopia and you find that there is a pituitary adenoma, invariably you will have a question whether if this adenoma is removed, will this patient have a visual recovery? So OCT now has been proven, there are papers which have proven now that OCT can safely tell you whether the patient would have a good recovery of his visual field or vision. If average retinal nerve fiber thickness is less than 70 in a patient who has pituitary adenoma, even after adenoma removal, he may not have a good visual recovery. Versus if his average nerve fiber layer thickness is more than 90, he is likely to have a good recovery of his visual fields or vision. Right? So OCT, use number 1, you can use to prognosticate in patients who have pituitary tumor. Use number 2, in patients who have optic neuritis, especially patients who have optic neuritis because of multiple sclerosis, they have found that there can be even thickening of papillomacular bundle. So apart from thinning of retinal nerve fiber layer, which will occur in any etiopathology which is causing optic nerve dysfunction, including glaucoma or optic neuritis, in patients with optic neuritis, because of multiple sclerosis, there can also be effect on thickness of papillomacular bundle. So that's the other use of OCT. Apart from that, a patient who had a subacute attack, a subclinical attack of optic neuritis, you will find a significant loss of nerve fiber layer thickness in the presence of normal optic nerve function. Right? So if scenario number 1, we are talking about approach to a patient with a pale disc or optic nerve pallor. You see a patient here where there are no other visual symptoms. Step number 2 would be you perform optic nerve function test. If optic nerve function tests are normal, you go ahead and perform visual fields or OCT. Even if that is normal, you just follow up the patient because this pallor is more likely. Then what can be the cause of this pallor? Is there any number which is given, capillary number? Kestenbaum's number, what is that? If it's less than 6? Yes. So Kestenbaum's number of capillaries on the surface of the optic nerve, I have not seen anybody really sitting and counting those capillaries, but you might be asked in the exam, and that's the reason why that question came up, and you are absolutely right. You count the number of capillaries on slit lamp. If the number of surface capillaries are less than 6, you are looking at probably optic atrophy. If the number is more than 12, you're looking at hyperemic disc. The 10 is what is considered as a normal number. So that's a Kestenbaum capillary number. Right. So other thing which can help you when you have this kind of scenario is if you have past records. If you know that this nerve didn't look like this few years ago, then you know that, oh, there is something which has caused this nerve to appear pale. Right? So am I really pale? In a normal setting, these are the things that you do. Past medical records. Lens status. Remember, the color of the optic nerve can be different depending upon if the patient has nuclear sclerosis. You might feel that nerve is little more orangish. Patient who has pseudophakia or aphakia, you will feel that nerve is little more pallor than usual. Even the examination technique, as Dr. Sood was mentioning, each equipment that you use would be different. Right? Or Dr. Devan was mentioning that each equipment that you use would be different. So the luminosity of your indirect ophthalmoscope or your slit lamp can also affect the color of the optic nerve. The general luminosity of indirect ophthalmoscope, the normal luminosity is 2000 lux. Or any other anomalies which can mimic pale disc, which would include myopic optic nerve. So we went through this. Is this optic nerve pale? You would perform all these optic nerve function tests. The list is here. If somebody wants to write it down, that's only for you to follow. What would you... please remember that OCT, though, can be a good test for you to see whether optic nerve, the nerve fiber layer is thin or not. If there have been studies which have shown if the patient has no long-standing perception of light, he would still have an optic nerve thickness around 45 or so. So in other words, if there is a long-standing no PL, you would expect a very thin or no nerve fibers, but when you measure it through OCT, you'll get the number of 40, 44, 45. And that you get because of presence of glial tissue. That you need to remember, because OCT is not a foolproof test for all optic nerve dysfunction. Let's look at scenario number 2, a 46-year-old female who has a loss of vision in the left eye for the last 6 months, and these are her visual acuity, and this is how her nerves look like. Right eye, left eye. It's the left eye where she woke up with a less vision, and her vision was 612 in the left eye. And this is how her optic nerve looked like. Yeah. Any thoughts? Yep. Yes. So now what you're talking about is a unilateral unilateral disc edema in the setting of loss of vision. What are the possibilities? So generally, these are the subgroups that you look at when you see a patient with an optic neuropathy, suspected optic neuropathy. It could be inflammation, optic neuritis. It could be ischemic optic neuropathy. A compressive lesion causing a disc edema, rare but can happen. A nutritional problems can cause optic nerve dysfunction. Optic nerve disc edema, the disc edema is not so common, and a hereditary optic neuropathy. So let's go from bottom ups. Can this patient, 46-year-old female, presenting to you with unilateral loss of vision with a 612 vision in that eye, can she be having hereditary optic neuropathy? Unlikely at this age. So do you mean to say the answer here from the audience for people who are sitting behind is that unlikely at this age? So do you want to say that all hereditary optic neuropathy should present to you early? Hereditary optic neuropathy can present to you in a third or fourth decade, but I agree that most of them would present to you early in the first or second decade. Right. So one age is against it. Anything else? Hereditary optic neuropathy are more likely to be bilateral, while what you are seeing here is a unilateral problem. Anything else? Absolutely, very good. Somebody said that acute loss of vision. So there are three things which are not matching: age, sudden loss of vision, and a unilateral optic neuropathy. Is there any condition which actually, is there any hereditary optic neuropathy which can present like this? Actually, Leber's hereditary optic neuropathy can present at any age. The highest age reported for LHON, though it's a hereditary optic neuropathy, is 66. It will have acute or subacute loss of vision. It would produce sequential loss of vision. So in other words, patient may come to you with a unilateral loss of vision. So Leber's hereditary optic neuropathy can produce this kind of picture. So is she likely to have LHON? Remember, LHON is transmitted by mitochondrial inheritance. In other words, females are carriers. The full-blown clinical picture is only seen in males. The most common age group is young male in teens, but it can occur at any age. So that's the reason why you say this is not a hereditary optic neuropathy. What about nutritional or toxic optic neuropathy? Again, nutritional or toxic optic neuropathy are more likely to be bilateral. Any nutritional or toxic optic neuropathy to be acute. Methanol poisoning is generally acute, but then would have other history and other clinical features, so that's how it's ruled out. What about compressive optic neuropathy? Can this be compressive optic neuropathy? Well, proptosis will occur if the compression is right in the orbit. If it's a little behind, you may not see proptosis. Yeah, you can. Proptosis will occur when tumor is big and anterior. A small tumor right at the apex may not produce proptosis, can produce disc edema. What is more important? You're right, disc edema also is not that common, but what is even more important is an acute loss of vision. Compressive optic neuropathy generally will have a progressive, gradual onset, progressive loss of vision. Only one scenario where compressive optic neuropathy can present to you with an acute drop in vision is if there is a sudden expansion of tumor. So tumor is sitting there for a long time, there is a bleeding in the tumor, yes, patient will present to you with an acute loss of vision, but that's a little rare. So what you're looking at is inflammatory optic neuropathy or ischemic optic neuropathy. 46-year-old female, what is your first differential? You're more likely to diagnose an ischemic optic neuropathy after the age of 40 rather than the inflammatory optic neuropathy. Now, if it's ischemic optic neuropathy, what are the types of ischemic optic neuropathy? First differential is anterior and posterior. Anterior, much more common. Anterior always will come to you with disc edema in acute stage. Posterior, less common, no disc edema. Posterior ischemic optic neuropathy actually is a disputed term, generally seen only in patients who had stroke or shock or blood loss or had a long surgery with all postural adjustments. That's where you will see posterior ischemic optic neuropathy. So ischemic optic neuropathy, there are two types, anatomically, anterior and posterior. Anterior is much more common. Now what are the types of anterior ischemic optic neuropathy? Arthritic and non-arthritic. Where do you see this patient going? Why? Painless, okay, debatable, more important. Please remember, arthritic anterior ischemic optic neuropathy is the disease of older age group. So generally patient is likely to be 65 and above, generally speaking. Versus a non-arthritic anterior ischemic optic neuropathy generally seen in 4th and 5th decade. Second important, yes. Vision loss, very good. In most patients with arthritic AION, you are likely to see profound impairment of vision. Patient would have 1/60, 2/60, even no PL vision. Versus here where vision is 6/12. What is the third important point? RAPD would be seen. Any unilateral optic neuropathy, with the exception of LHON, you will see RAPD. So, what is the third important point is optic nerve, appearance of optic nerve. Yeah. In an acute stage, in a non-arthritic AION, you will find hyperemic disc with a sectoral hyperemia and pallor, versus in arthritic AION, you will find, most of the time, you will find a sudden infarct. So there will be a pallor which is, even if the symptoms are only for a week or 10 days, patient would already have a pale disc, right? And another important thing, once arthritic AION progresses, after 6 weeks to 8 weeks, patient can actually develop even a cupping. So this is how you manage a non-arthritic AION. One of the important things which is missed many times is to ask for sleep apnea. If patient has sleep, the question that you can ask your patient who is having ischemic event anywhere in the body, including AION, is does he snore at night? If he's snoring at night, he might be having sleep apnea. So get it evaluated by neurologist. If patient is having sleep apnea, it's good for the patient to treat sleep apnea. And there is sort of an anecdotal evidence that if you treat sleep apnea, you at least saved the other eye. You're not very sure whether you'll be able to improve the vision in this eye, but you have saved the other eye because you have removed one of the risk factors for ischemia. The other important thing to consider is if a male patient is taking Viagra, then he should discontinue because there is a direct correlation of erectile dysfunction drugs and ischemic optic neuropathy. Amiodarone has to be substituted and smoking has to be stopped. Versus, that was a 46-year-old female. This is a 70-year-old female with a sudden painful loss of vision, notice in the morning. And this is how the nerve looked like. Now this is arthritic AION. 70-year-old female, profound visual impairment. And you see already in 1 week or 2 weeks, you're finding all these nerve fiber layer infarct around the disc. All right. So what is typically described in a textbook as a pallid disc swelling is what you will see in patients with arthritic AION. Now, what is the importance of differentiating between the two or diagnosing arthritic AION early? Because it's a medical emergency. So you need to get the ESR done immediately. I mean, in an exam, you might be even expected to tell that you would admit the patient, get the ESR, CRP done, start steroids immediately. Why are you doing all this? Exactly. Please remember that steroid may not do much to the eye which is already affected, but it's a systemic disease and your duty is to make sure that the other eye is not affected, because once the nerve is infarcted, he is not likely to recover the vision. Okay? So this is the scenario which we discussed, pale or swollen optic disc in the setting of ischemia. We looked at two examples, a 46-year-old female and a 70-year-old female. Arthritic or a non-arthritic AION. Now remember, the important point is in a small number, generally speaking, Ischemic optic neuropathy, vision goes down and it stays there. In 20% of the patients, there can be a little improvement after 4 to 6 months. In inflammatory optic neuropathy, the vision improves by 6 to 8 weeks. While in ischemic optic neuropathy, a small percentage will improve after up to 6 months. But there could be a scenario where patient may have a progressive loss of vision. The number might be small, but if you find a patient with a progressive loss of vision in the scenario of non-arthritic AION, patient should be referred to nephrologist. He might, in patients who have hypertension, diabetes, they are at risk of developing AION. They are also at risk of developing nephropathy. And there is a belief that patients who have nephropathy are likely to develop progressive form of AION. 25-year-old male with a gradual loss of vision in both the eyes for 6 months. Vision is 6.9 in the right eye, 6.60 in the left eye. Your comments. Which eye looks more abnormal? Left eye. Patient also has the symptoms in the left eye, though his vision in the right eye is 6.9. So left eye looks abnormal. Any comments on the appearance of the left eye? Yes. Here the answer came in. It appears like a bow tie optic atrophy. So it appears maybe not very impressive. Well, it's fine. The poles look reasonably normal. The pallor is more on the nasal and temporal part of the optic nerve. This is described as band-shaped optic atrophy or bow tie optic atrophy. Any idea what could be the reason? Yes. Chiasmal compression typically can produce bow tie optic atrophy. Okay, not only chiasmal compression, chiasmal lesion, but whenever there is a compression of the nasal fibers from the eye which serve the temporal visual field, if they are compressed, patient may have in that eye a bow tie optic atrophy. This is how the visual field look like. So you had a class on visual field. What do you think? Right, left? What do you think in the left eye? What do you think about the left eye? Left eye is profound visual impairment, and there is absolutely nothing in the central visual field. Right eye glaucoma? Okay, so what are the types of junctional scotoma? Do you know who gave the name junctional scotoma? Junctional scotoma of Tracquer. Tracquer, when he described the junctional scotoma, he described only this defect. It is no defect in the other eye. But now all types of these scotomas are also called junctional scotoma. Junctional scotoma meaning thereby that here the optic nerve is completely gone and a supratemporal defect in the contralateral eye. It happens because of why? Because of compression of fibers which curve around in the opposite nerve. Those fibers are called genu of von Willebrand. Okay? So, junctional scotoma, you said that optic chiasm is where you will find patient have pituitary adenoma. So, please remember, pale disc in the setting of progressive loss of vision has to be investigated, and you would generally end up ordering neuroimaging. Last case, a 28-year-old female, both eyes dimness of vision for last 6 weeks. Her visions are given here, 624, 69. This is how her optic nerves look like. What do you think? So, young female, obese female, bilateral, gradually progressive loss of vision for last 2 months or so. This is how her optic nerves are looking like. Yeah, number one, please don't use benign intracranial hypertension. It is not a very benign condition, and that term has been given up. So there are two conditions that you can, or two terms, either pseudotumor cerebri, PTC, or IIH, idiopathic intracranial hypertension. So these are the criteria. Idiopathic intracranial hypertension is like glaucoma. It generally occurs because of raised pressure. You would like to do MRI, MRV. Why would you like to do MRV? MRV is MR venogram, you would look at sagittal sinus thrombosis. The important, and this is the last slide, important symptoms that you should remember a patient who can have raised ICP are transient visual obscuration, generally described as browning of vision. So in other words, patient who has a disc edema, it can be inflammatory pathology, ischemic pathology, or raised ICP. Raised ICP is likely to be bilateral, while inflammation and ischemia would be unilateral. Any patient who has a pale disc and a progressive symptoms or progressive loss of vision should be investigated. Thank you very much.